Welcome back to the deep dive. Now, if you are an emergency medicine doctor navigating, the often brutal waters of UK training, this session is tailored specifically for you. You're working toward that final level of trust. And today, our mission is to cut straight through the complexity.
Right.
We are taking a strategic deep dive into the source material that defines how to achieve full entrustment in RCEM Specialty Learning Outcome 4.
Care for acutely injured patients across the full range of complexity.
Yes, Levin.
And that SLO4 mandate, it's really the ultimate goalpost, isn't it? It demands so much more than just treating trauma.
It's the whole spectrum.
The whole spectrum. From the minor injury unit right up to the major trauma center resusc. We're looking at, combining top-tier clinical skill with systematic leadership.
And protocols.
Rigorous adherence to national protocols like NICE guidelines, and crucially, that documented engagement in quality improvement, QI.
Okay, so let's unpack the career progression model. Because the move from, say, an intermediate trainee to a higher trainee is often where people get tripped up.
It is.
It's not just about doing the procedures. It's about owning the system. What are the key milestones that the Faculty Entrustment Group, the FEG, are looking for?
It's all about increasing levels of responsibility and independence. The first stage is what we call foundational skills.
So ACCS level.
Exactly. The ACCS level, this is the bedrock. Can you independently run a primary and secondary survey, the whole CABCDE, safely?
And the basics.
And the basics. Managing straightforward wounds, basic fractures, and confidently using safe local anesthetic techniques.
I guess the starting line. So where does it shift into the registrar's domain?
The next jump is the intermediate training target. And here the expectation shifts dramatically. You have to be able to provide leadership of the trauma team.
So you're in charge of the room.
You're directing the flow, you're assigning the roles, managing the initial plan. But, and this is the critical bit, your educational supervisor is still on call.
So they retain the ultimate responsibility.
Exactly, the ultimate legal responsibility. You lead the team, but the accountability still rests one step above you.
And then comes the big one, higher training, the final stage for SLO4 entrustment.
This is where the standard becomes true expertise. You have to move from just providing leadership to providing expert leadership of the major trauma team.
And what does that actually mean in practice when the consultant isn't in the room?
It means demonstrating strategic, independent command, rapid decision-making when your consultant is only remotely available. And that distinction, leadership versus expert leadership, that's what the FEG scrutinizes.
So they need rock-solid evidence.
Rock-solid evidence you can handle it all. The coordination, the crisis, the move to definitive care, all of it, independently.
That frame is crucial. Okay, let's move into our first section. Because while the high-stakes polytrauma grabs all the attention, the sources really emphasize that the foundation of entrustment is laid in consistent competence in the, the loaded intermediate complexity stuff.
Precisely. The things you see every single day in a UK ED.
Right.
If you can't manage a forearm fracture or a contaminated wound safely and thoroughly, you can't be entrusted with the complex cases. For intermediate and higher trainees, wound management is mandatory.
And that's more than just putting in a few stitches.
Oh, way beyond that. You must show competence in multiple closure techniques, suturing, adhesives, steri-strips, and vitally, you have to mandate the right imaging.
The right imaging being.
What exactly?
It means using X-ray, CT, ultrasound, sometimes even MRI, not just to see the bone, but specifically to rule out a vascular or a neurological compromise.
Looking for the injury you could miss.
Exactly. Your notes have to reflect that diagnostic thoroughness. Entrustment is all about not missing things.
And when we talk about pain management, especially for things like closed reductions, we have to talk about regional blocks and procedural sedation, PSA.
This is absolutely non-negotiable in modern trauma care. You have to master essential regional blocks. And look, the sources are specific here.
The fascia iliata block, the FIB, is highlighted as a key procedural expectation. It's safe, effective, and makes a huge difference for hip and femur injuries.
And for your portfolio, you've got to document more than just block successful.
Oh, absolutely. The anatomical knowledge, the aseptic technique, the post-procedure monitoring, all of it.
Let's focus on the governance of PSA, because this is where liability and risk management really kick in. What are the key principles for a higher trainee running a sedation?
The principles are absolute. First one, analgesia precedence.
Meaning?
Meaning adequate analgesia must always be in place before you give the sedative agent. Sedatives are not painkillers.
Right. A very common mistake to make.
It is. If you skip that, you risk a distressed, moving patient and a poor outcome.
And the monitoring standards. What happens if they slip?
They cannot slip. It's that simple. If the patient's consciousness is reduced to the point they can't respond to you, they must have the same level of physiological monitoring as a patient under GA.
So continuous capnography, SATs, regular BP.
The works. Failure to comply with that level of safety makes entrustment completely impossible.
We often see debates about staffing for these procedures. What does the evidence say about the team model for, say, a closed reduction under sedation?
The standard is that the one physician-nurse model is effective and safe. But, and here's the bit for the FEG, the trainee must show they are following stringent safety protocols.
Like checklists.
Exactly. The mandatory use of pre-procedure checklists and continuous monitoring throughout. The efficiency of a small team cannot compromise the safety standards. They want to see you balancing that.
Excellent. Okay, let's shift gears to the really high-stakes management. We're moving into Section 2, Major Trauma Resuscitation, which in the UK is governed by NICE Guideline NG39.
This is the domain of expert judgment. The sequence is fixed, of course. Primary survey first. For airway, if the patient can't maintain it, RSI is the mandate.
And if RSI fails?
Then the trainee has to show they're ready to immediately pivot to a basic adjunct, a supraglottic airway, or move straight to a surgical airway.
Okay. An imaging strategy in the trauma bay. It's a balance of speed and caution, isn't it?
Yeah.
Especially with different age groups.
It is. Speed is vital, but so is judgment. For adults, 16 and over with suspected severe chest trauma who are stable or responding, immediate whole-body CT is recommended.
The rapid diagnostic pathway.
That's it. But the trainee must demonstrate the crucial distinction. Routine CT should not be the first-line imaging for chest trauma in children under 16.
Right. Different pathways for kids.
Reflecting the pediatric guidelines, a critical distinction.
Now, for the really interesting bit, damage control resuscitation, or DCR, mitigating that lethal triad of hypothermia, acidosis, and coagulopathy. This is where practice has shifted so much. What are the mandatory fluid targets under NICE NG39 for a higher trainee?
The UK standard is, it's uncompromising, a restrictive approach to volume in actively bleeding patients. You have to titrate fluids to achieve very specific endpoints.
Sure.
A palpable central pulse pre-hospital, or just maintaining central circulation in the hospital. And you do that only until you get definitive hemorrhage control.
Now, wait a minute. Holding back crystalloid in a patient who's crashing goes against every basic instinct, doesn't it?
It absolutely does.
What's the biggest risk of not doing that, even if their BP is low?
The risk is you worsen the coagulopathy and the acidosis. You fuel the lethal triad you're trying to stop. The mandate on fluid choice is crystal clear.
No crystalloids.
In hospital, for active bleeding, crystalloids must not be used for volume replacement. The strategy for adults is blood products only, and a high ratio.
Of a 1.1 ratio.
A mandatory 1 unit of plasma to 1 unit of red blood cells, the 1.1 ratio. That's critical for replacing clotting factors early.
And there are drugs that have to go in without delay.
Absolutely. 5-E tranexamic acid, TXA, is mandatory as soon as possible within 3 hours. The CRH-H2 data on that is just so clear.
And for warfarin reversal.
For emergency reversal of vitamin K antagonists, the only acceptable initial treatment is prothrombin complex concentrate, PCC, immediately, not plasma.
This nuanced decision-making brings us to what feels like the ultimate test of competence. Managing the co-dominant injury
Yes.
when you have traumatic brain injury and hemorrhagic shock at the same time.
It is the tightrope because these two injuries have completely conflicting resuscitation goals.
Right. TBI wants a higher blood pressure, shock wants a lower one.
Exactly. The expert TTL has to perform a dynamic risk assessment to decide which condition is dominant right now.
And your evidence, say a CBD on this, has to show that thinking process.
It must articulate the physiological rationale. Why did you choose restriction, or why did you choose to liberalize your volume target in that exact moment? The FEG wants to see you thinking under pressure.
That moves us perfectly into Section 3, expert leadership and system accountability. When the consultant is remote, what does the trauma team leader have to do to prove they are managing the system, not just the patient?
The TTL's role is executive. You own the entire system flow until handover.
So that means liaising with other teams.
Strategic oversight. Talking to the named anesthetic consultant about the airway plan, and crucially, working with the site manager to make sure there's a bed in theater or ICU ready to go. Seamless flow.
And there's a non-negotiable mandate around imaging. that really shows that oversight?
Yes, the CT scanner mandate.
Go on.
The TTL, or the MTC consultant, must always attend the CT scanner with the patient. This isn't optional.
Why is it so important?
Well, it's a critical safety point for continuous hemodynamic monitoring. But mainly, it's about being there to make an immediate, on-the-spot decision about the post-scan destination. It prevents any delay. It's a quantifiable indicator of system management.
And how should a trainee document their team's supervision and delegation?
Effective delegation means assigning one team member specifically to write everything down contemporaneously.
But the TTL is still responsible for it.
The TTL retains ultimate responsibility for checking that documentation for accuracy. You delegate the task, never the accountability.
Okay, so what about showing non-technical skills, NTS? We're talking human factors now, beyond just clinical skill.
Expertise relies so heavily on NTS. Decision-making, teamwork, situational awareness. Trainees should be proactively seeking objective feedback on this.
Using specific tools.
Yes, using validated tools like TNO-TEAS, which is the non-technical skills scale for trauma during resuscitations.
For those not so familiar with it, what does TNO-TEAS focus on that other tools might miss?
It focuses on observable behaviors, things like workload management, how you prioritize tasks, how you communicate, and maintaining situational awareness when everything is chaotic. It moves assessment beyond was the RSI successful to how well did the leader manage the team during the RSI.
And I'm guessing simulation, SBL, is central to this.
Absolutely mandated for TTL training. You have to use those scenarios to get formal WBA feedback on your NTS. And what's more, the hired trainee is expected to lead a multi-professional debrief immediately after a major trauma.
That's a key governance activity.
It is. It moves beyond the individual and helps the whole system learn and improve.
And connecting that leadership back to system accountability requires documented QI, quality improvement.
Correct. Participating in local or national audit is mandatory. You must document and lead a measurable QI project related to trauma and have it assessed using the QI8, the Quality Improvement Assessment Tool.
To prove you're not just a cog in the machine.
You're proving objective system mastery. Designing a project that improves compliance with the 1.1 blood ratio or reduces time to TXA. Tangible improvements.
That transition from brilliant doctor to system leader is so key. So let's focus now on the listener's e-portfolio. How do you map all this complex evidence successfully for the FEG?
First thing, focus on quality, not quantity. The curriculum is very clear that the quality of reflection is far more important than the volume of WPBAs.
But there are rough targets.
A rough guideline is maybe one observed clinical episode, a mini CX or an ESLE per week. But prioritize complexity. And you need at least 3 solid, enhanced, structured learning experiences, ESLEs, per year.
So how do we strategically link the evidence to those complex capabilities we've discussed?
You use the right tool for the right job. For demonstrating TTL expert leadership and NTS, you must use an ESLE from a simulation or a live trauma.
And the feedback needs to mention the system stuff.
Exactly. Delegation, coordination, and your reflection has to mention attending the CT scan or liaising with the site manager.
And for that clinical tightrope, the TBI and shock conflict.
For complex trauma management like that, you use a CBD, a case-based discussion. It's the perfect tool to analyze your decision-making under uncertainty. The discussion should be about the why behind your choices.
And what about procedural evidence, the FIB, for example?
For procedural competence, like a fascia iliaca block or sedation, you use a DOPS or a mini CEX. And the write-up must explicitly verify you followed all the PSA safety guidelines, the monitoring, the analgesia first rule.
And finally, governance and QI.
That has to be a QI. It's the only way to show measurable, sustained improvement linked to national standards.
The reflection has to be more than just, this is what happened.
Oh, absolutely. The reflection must be critical. It needs to analyze how effective your delegation was, how well you stuck to DCR protocols, and what you actually learned. You have to link the clinical activity back to the SLO4 key capabilities and show you are growing into that self-regulating expert.
We've established 3 clear pillars for SLO4 entrustment. Let's just quickly recap those for the listener.
Okay. First, clinical breadth. That means procedural mastery, like the FIB, and evidence-based execution of DCR protocols, so the 1.1 ratio and no crystalloids. Second, expert leadership. Demonstrated by strategic TTL command, including that absolute mandate of attending the CT scanner. And third, system accountability. Evidenced by your QI projects, assessed by the QI8, showing you are making measurable improvements to the system.
That progression from foundational skill to strategic system master. That's the journey the FEG needs to see.
The final message is this. Achieving SLO4 is about demonstrating reliable self-regulation and system mastery. The technical skills are assumed at this level. It's the leadership, the governance, the ability to reflect critically. Those are the differentiators.
And here's a provocative final thought for you to explore as you strategize your portfolio. Given the sources emphasize the TTL's role in system improvement, how does your current mandatory debriefing process actually drive measurable system improvement in your department? Challenge yourself to think beyond just reflecting on the individual case. Look at its measurable impact on your department's compliance with national standards. That is the true test of system leadership.
A powerful point to end on.
Thank you for joining us for this deep dive into SLO4 entrustment. We hope this helps you focus your efforts and strategically plan for that final entrustment decision.